Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the differences between diabetic ketoacidosis and hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state is also called hyperosmolar hyperglycemic non-ketotic state. So we can use the word HHNS. So how about diabetic ketoacidosis? Primarily occurs in younger patients with type 1 diabetes. We know that type 1 diabetic patients are younger, but can also occur in type 2 diabetes. That happens rarely. It results from a severe deficiency of insulin, leading to hyperglycemia, ketosis. Here there is lack of insulin, severe lack of insulin that will lead to burning of fat for energy utilization. That's why there will be formation of ketone bodies. Ketone bodies are the beta-hydroxybutyric acid, acetoacetic acid and acetone. These are acids, so there will be accumulation of ketone bodies that will lead to metabolic acidosis. So pH will be less. In hyperosmolar hyperglycemic non-ketotic state, typically occurs in older patients with type 2 diabetes. We know that type 2 diabetic patients are older. It is characterized by profound dehydration. We must emphasize on this word, profound dehydration, extreme hyperglycemia, and increased plasma osmolality. These three are very important. Increased plasma osmolality without significant ketoacidosis. Even there will be no ketone in the body. That may happen in hyperosmolar hyperglycemic state. Unlike diabetic ketoacidosis, insulin level in hyperosmolar hyperglycemic state are sufficient to prevent ketosis but not enough to prevent hyperglycemia. So, no ketone, more ketone, hyperglycemia, more hyperglycemia, dehydration, extreme dehydration, presence of ketone, almost no ketone. Okay, these are the differences. We'll go further. Diabetic ketoacidosis, lab values and symptom. Diabetic ketoacidosis, blood glucose level are usually high, typically above 300 mg per dl. That means deciliter. Range is around 250 to 500 mg per deciliter, and ketosis is present. That is important. Diabetic ketoacidosis, so will have ketone bodies. Ketones such as beta-hydroxybutyrate and acetoacetic acid, these are measured, are elevated. pH, that is the negative logarithm of hydrogen ion concentration, is less than 7.3 because it is a state of metabolic acidosis. Symptoms may include polyuria, increased frequency of micturition, polydipsia, excessive thirst, polyphagia, excessive hunger, abdominal pain. This is due to ketone body in the body. That's why there will be abdominal pain, nausea, vomiting, fruity smelling, also called acetone breath, hyperventilation, shallow but tachypnea, increased rate of respiration. We call it Kussmaul's respiration, fatigue, confusion, and potentially coma. In case of hyperosmolar hyperglycemic state, blood glucose levels are extremely high, often exceeding 600 mg per deciliter. Unlike diabetic ketoacidosis, there is little to no ketosis. Potassium depletion is severe. Potassium depletion may be also possible in diabetic ketoacidosis, but here it is severe. Symptoms are similar to diabetic ketoacidosis like polyuria, polydipsia, polyphagia due to extreme hyperglycemia, but we must emphasize dehydration symptoms are prominent in HHS, that is hyperosmolar hyperglycemic state, such as extreme thirst, dry mouth, neurological manifestation, confusion, obtundation is very common in hyperosmolar hyperglycemic state. Neurological manifestation is less in diabetic ketoacidosis. And in case of hyperosmolar hyperglycemic state, there is no Kussmaul's respiration because there is no compensatory respiratory hyperventilation in here. This is happening compensatory hyperventilation because of metabolic acidosis. Here it is absent in case of HHS. Okay, so here it is absent. No Kussmaul respiration, no acetone or fruity breath. This is a ketone body, so there is no ketone here, so no fruity breath. Diabetic ketoacidosis onset and progression. Okay, diabetic ketoacidosis typically has a rapid onset and progression can be swift, often over hours to days. Risk factor: diabetic ketoacidosis commonly occur during periods of illness, infection, stress that increase the body's demand for insulin. How about HHS? Onset is usually more gradual compared to diabetic ketoacidosis, often over days or 2 weeks. It tends to progress more slowly but can still lead to severe complication if untreated. Risk factor: often associated with condition that leads to dehydration such as infection, heart failure, renal failure, or medication that increases blood glucose level like that of corticosteroids. Diabetic ketoacidosis versus hyperosmolar hyperglycemic state. Mortality and complication. Both diabetic ketoacidosis and hyperosmolar hyperglycemic state can lead to life-threatening complication if not promptly treated. Diabetic ketoacidosis has a higher mortality rate due to the associated metabolic acidosis. Electrolyte imbalance and potential for cerebral edema. Cerebral edema may happen due to rapid correction of hyperglycemia in both cases. Both diabetic ketoacidosis can lead to life-threatening complication if not promptly treated. Hyperosmolar hyperglycemic state, on the other hand, carries a higher risk of vascular complication because of extreme hemoconcentration. Blood is very concentrated because too much glucose occur in may cause thrombosis and embolism due to extreme hyperosmolarity. Treatment of both conditions involves aggressive fluid resuscitation with normal saline. Because this is isotonic, normal saline. Correction of electrolyte imbalances, insulin therapy. Correction of electrolyte imbalance is very important. Particularly the potassium. It should need a lot of precaution, otherwise there may be cardiac arrhythmia. Correction of electrolyte imbalance, insulin therapy. Initially we give regular insulin, then it will be converted into that of the subcutaneous insulin. With hourly monitoring of glucose, it should go slow. Rapid correction will lead to cerebral edema. In case of defective kidney, there may be acute kidney injury too. So, to avoid cerebral edema, we must go slowly. And hourly monitoring of glucose and ECG is very important. Okay, because if we drip potassium along with the saline, we must look at the cardiac function. There may be chance of hyperkalemia or hypokalemia. Heart may not work. Addressing the underlying cause is very important too. However, the specific management strategies may differ based on the individual patient condition and the severity of the presentation. Okay. And that's all about the differences between the diabetic ketoacidosis and that of the hyperosmolar hyperglycemic non-ketotic state. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.